all ISCOT participants. First of all, I would like to thank the organizing committee who invited me to talk today. And the topic that I'm going to deliver is a dermatological manifestation due to preventive measures of COVID-19. My name is Dr. Dana. I'm a board certified dermatovenerologist from Jakarta, Indonesia. And this is my disclosure for these talks. And this is my outline for today's topic. COVID-19, caused by SARS-CoV-2, is currently a pandemic worldwide since it first identified in Wuhan, China on December 2019. Although pulmonary health has been the primary focus on the early days of COVID-19, an increasing prevalence of cutaneous manifestations in COVID-19 has been reported. When we talk about dermatological implications of COVID-19 fall into four groups, according to Al-Mutairi and friends. The first one is primary cutaneous manifestations of COVID-19 or viral exanthema. The second is skin changes from the use of personal protective equipment or PPE and doing personal preventive measure or PPM that we are going to talk about. The third is adverse drug reactions to COVID-19 medication. And the last is exacerbating primary skin disease due to COVID-19 infections. One of many means of mitigating the spread of the virus is wearing a mask and doing hand hygiene by general population and healthcare workers. A variety of PPE has been used, especially by healthcare workers. Unfortunately, hand hygiene practice and the use of PPE carry risk of skin barrier dysfunctions and sometimes aggravating the pre-existing skin condition due to prolonged contact time and increased frequency of use. These dermatoses need to be prevented, identified, and managed to maintain compliance from healthcare workers and general public as well. These are cutaneous effects that can occur by doing preventive measures and using PPE. Reported by Lin and others in 376 subjects of healthcare workers and general society in China, 70% of them reported adverse skin reactions, with 68.6% suffer dryness or desquamations, 60.4% reported erythema, and 52.9% experienced macerations. Hand, cheeks, and nasal bridge were the top three affected area. Report by Pei and others from 484 healthcare professionals in China found that pruritus is the most common symptoms. A multi-center cross-sectional study by Jiang and others found that the most common skin injury is due to the pressure, while Elston and others found that dermatitis is the most common dermatosis. According to these reports, hand eczema are frequently associated. And these are reports that classified the dermatosis according to the locations of skin injury. Obviously, the most affected area are face and hands. By doing PPM and using PPE, skin reactions can happen related to mask and eyewear, related to tropical climate, gown and caps, and related to hand hygienes and gloves. These are several skin adverse events due to the use of masks that we are going to discuss below, including acne, pressure injury, dermatitis, and others. Acne or maskne or mass acne, that's what the terms we commonly heard these days. In 2006, publications by Fu and others in Singapore during SARS infection era helped workers with working time 8 hours a day for 8 months. 35% of them reported adverse skin reactions, and 60% of it are maskne. The lesion mostly found on the area that covered by mask. The mask, googles, can create a hot, humid microclimate, resulting in excess sweat and sebum accumulations on the face. These promotes the growth of P. acnes, which predispose acne flare-up. Pre-existing acne with repetitive pressure friction from masks and goggles can cause pilosebaceous ductal occlusions and aggravate pre-existing inflammatory lesions. While patients with no prior history of acne can develop acne mechanica, as mechanical trauma can cause ruptures of microcomedones that cause inflammations. We can prevent acne by doing mask breaks for 15 minutes every 2 to 4 hours in sterile area, and surgical masks need to be replaced with a new one every 4 hours. Use facial cleanser containing salicylic acid and topical benzoyl peroxide before and after masking. It is advisable not to use any cosmetic. Use oil control moisturizer to decrease sebum secretion, and use hydrocolloid bandage for inflammatory lesions. The treatment of acne is basically the same with regular acne, but we have to consider the concentrations of retinoic acid being used to minimize risk of skin irritations. Use non-comedogenic oil-free moisturizer in case of oral isotretinoin treatment. So this is my patient, a 49 years old lady with no prior history of acne. This is the before picture, and this is 4 months after I treat her. The acne is stabilized. But as you can see, there are linear erythema lesions caused by pressure that we are going to discuss on the next slide. PI, or pressure injury, characterized by skin indentations and mild erythema on the mask cover area due to constant pressure on the same site frequently that can lead to blister, erosions, ulcer, or secondary infection. According to Geffen publication, there are 3 pathomechanisms of PI. Number 1 is increase in transepidermal water loss. The second is a relative temperature and increased humidity that generate a change in skin microbiome that leads to inflammatory response and risk of infections. And the third is a production of inflammatory mediators that leads to productions of reactive oxygen species. There are 4 stages of PI. Stage 0, when the skin is look normal. Stage 1A, there are skin indentations on the nose bridge and the malar area with or without erythema that resolve in less than 24 hours. This is related to the use of face mask less than 6 hours, not consecutive day. There can be burning sensations but no pain. Stage 1B, I experienced it myself in this picture. There is a persistent non-blanchable erythema that persists more than 24 hours. Edema and indurations can be found, accompanying by pain and heat. This stage related to the use of face masks more than 6 hours every day. Stage 2, characterized by crust, edema, and indurations. The wound compromised the dermal layer of the skin. Stage 3, superficial ulcer, can be found, clinically visible as an abrasion or blister. The wound compromised the subcutaneous layer. And stage 4, if the pressure continue without any prevention or treatment, a deep full thickness pressure ulcer will appear, bone, muscle, and tendon might be exposed. To prevent PI, we can use a gentle pH balanced face cleanser, use a silicone gels over potential site of pressure, use thin hydrocolloid dressing to minimize the pressure intensity, and avoid petrolatum or oil-based product, and also thick dressing that can compromise the integrity of the mask. This is the example use of several patch like benzalkonium chloride, hydrocolloid, hydrogel in pressure area prior donning a mask. And we can also relieve the pressure by minimizing durations of pressures, like frequent mask break about 10 to 15 minutes, every 2 to 3 hours, and moisturize with lipid or ceramide base to maintain skin barrier integrity. These are PI treatment recommendations by Aguilera and friends. Stage 0, no treatment needed. Stage 1, use moisturizer or aloe vera. Stage 2, for crust, abrasions, or open wound, give a restorative cream contained of zinc and copper or silicone gel, and on top, put on the hydrocolloid patches. As in stage 3 and 4, is recommended to refer to our plastic surgeon colleagues for debris demang and flap surgery. Masks also can induce dermatitis like seborrheic dermatitis, irritant contact dermatitis or ICD, and frictions dermatitis caused by mask and mask trap. This has happened to myself as well in my retroauricular part that contact with the straps of mask. Allergic contact dermatitis or ACD due to mask components such as metal clips, rubber straps, and adhesive material can occur. Case of ACD to Thioram, Carbamix, acrylates, etc., which all integrated part of mask have been reported. Patch and skin prick tests may be required to make the diagnosis, and if confirmed, appropriate mask substitutions is needed. These are preventive measures by modified mask strap to relieve retroauricular pressures, or choose a head loop mask instead. The treatment is topical steroids mild to moderate potency, topical antifungals for seborrheic dermatitis, emollient to protect skin barrier from further damage, skin protectants like silicone gel to minimize frictions, and allergen avoidance in case of ACD. Of course, mask use have a risk of secondary infections like impetigo and folliculitis that need to be treated with antibiotics. Contact or delayed pressure urticaria can occur, so take prophylactic non-sedating oral antihistamine 1 to 2 hours prior to shift duty. Cheilitis or lip liquor dermatitis can be prevented with petroleum jelly or fragrance-free lip balm before and after using PPE. Facial pigmentations has been reported from healthcare workers due to PIH or rarely from pigmented contact dermatitis. Treatment options are azelaic acid, retinoic, and hydroquinone. Goggles can cause adverse reaction as well. This is a case report from China of Google mask-related impetigo on infraorbital regions, treated with an oral and topical antibiotics. Gowns, as well as head caps and tropical climate, can induce dermatosis too. Like this case of sweat-induced dermatitis caused by the use of occlusive and synthetic non-absorbent clothing, accumulations with sweating, moisture, and friction. Malassezia globose, reported by Takahagi and others, responsible for producing histamine-release antigen in human sweat, exacerbating urticaria and atopic dermatitis. Hyperhidrosis conditions have acidic pH that can promote T helper 2 and 7 mediated inflammations that worsen pruritus and skin irritation. High temperature also can induce vasodilatation and sinews fiber that cause pruritus. Any area from scalp down to toe that covered by PPE can cause dermatosis due to hyperhydration effect, like this PI on the neck, SIBO psoriasis, intertrigo, and folliculitis. ACD can occur due to formaldehyde present in disposable gowns or caps. The prevention is frequent break in non-contaminated area that well ventilated with cooling device. Wear a thin, cool cloth beneath the gown that can mitigate heat and humidity. Cleansing with gentle soap-free cleanser and moisturize regularly. It is recommended to keep the hair short and avoid hair contaminations and easy for cleansing. The treatment recommendation is non-sedating antihistamines for urticaria or intense pruritus, mild topical steroids for miliaria, and antifungals for fungal infections. Flare of dermatitis or psoriasis should be managed with topical steroids, emollients, and avoid triggers. Patch tests needed if textile ACD is suspected. The last part that I'm going to talk about is the dermatosis related to hand hygiene and the use of gloves. This is my patients with ICD due to overzealous hand hygiene. These patients never moisture and probably use a harsh cleanser. Hand hygiene can expose the skin to factors that compromise the skin barrier, alter the hand microbial flora, and cause contact dermatitis. Exogenous factors like winter season, low humidity, and low temperatures can influence as well. A study by Lin and others documented 84.6% healthcare workers reported the hands as the most common site affected PPE-related dermatosis. Majority of them wash their hand more than 10 times a day, but only 22.1% moisturizing after wash. Alcohol-based hand rubs that contain 60% ethanol or 70% isopropanol shown to inactivate the virus. This hand sanitizer is more convenient, less skin damage than hand washing, and improve compliance to hand hygiene. And gel formulation shown to be better tolerated compared to liquid formulations. True allergic reaction to alcohol-based formulations are uncommon. Other allergic reactions can caused by other excipients or preservatives in the alcohol-based hand rubs. Alcohol-free hand rubs that contain benzalkonium chloride or BAC has been approved for the formulations for hand hygiene, although still limited data on the efficacy of BAC against bacteria and virus compared to the alcohol one. We have to be aware that BAC is a well-known irritant, in some cases a contact allergen as well. For the prevention, use mild moisturizing cleansing products followed by topical moisturizer, ceramide content for instance. For barrier repair, while applications of emollient will not affect the efficacy of hand sanitizer. Accessories such rings should not be worn on duty, as irritants and chemical may accumulate underneath them during zealous hand hygiene practice. For treatments of hand dermatitis, topical corticosteroids for ICD or antibiotics if secondary infections occur. Topical calcineurin inhibitor, frequent use or barrier protections, and repair creams help restore the integrity of the stratum corneum. Make sure the skin is fully recovered before resuming duties. Patch tests can be performed if needed. Besides hand hygiene, ICD can be related to the use of gloves. A lot of health workers doing double gloving for better protection. But this is not always recommended, especially in hot, humid climate that can compromise the skin barrier leading to irritations. Glove also can induce ACD. Latex composed of chemical accelerator and natural rubber latex protein. The chemical accelerator or rubber additive in medical glove is the most common cause of ACD or type 4 hypersensitivity reactions in healthcare workers, while natural rubber latex protein can cause true latex allergy or immediate type 1 hypersensitivity reaction that presents in a spectrum of contact urticaria to life-threatening anaphylactic. Skin prick test is gold standard for diagnosing type 1 latex allergy and should be done in a hospital setting with medical staffs and latex-free resuscitation equipment available, while patch test is a gold standard for evaluations of type 4 reactions to rubber additive. For prevention and treatment, use non-powder, reduced proteins, and low allergen latex gloves by all workers, and non-latex gloves by sensitized individuals. Wear plastic or cotton glove beneath the latex glove. Make sure the hands are completely dry before donning PPE. Topical steroids for inflammations and the use of emollients for skin barrier repair. Avoid oil petrolatum base that can compromise the gloves. So as a conclusion, wearing a proper PPE and doing PPM by healthcare workers and general populations are important during this pandemic. However, by doing so, the breakdown of skin and mucous barrier become prone and can cause skin adverse event. Dermatologists can play a role, provide professional advice on prevention and management on these skin disorders, while provided a recommendation guideline on prevention and management for
kulit, pertahanan pertama tubuh kita, yang mencegah hilangnya air dari tubuh dan masuknya stimulan eksternal. Noroid, professional solution for healthy skin. Noroid mengandung